A very good evening to all. I cordially invite you to the 8th session of Pulmocon 2021. Today's topic is about organ affections in COVID-19 rehabilitation. To chair the session, I would like to invite Dr. Professor Arup Kumar Kundu. Dr. Kundu is a big name today. He has graduated and postgraduated in medicine from Calcutta University. He is an internationally renowned author of clinical medicine and clinical methods. Hardly anybody in the subcontinent gets the graduation cleared without going through Dr. Kundu's book. He has contributed many chapters in national and international bestsellers in medicine. He is also one of the active member of the international advisory panel of Kumar and Clark's medicine book. Dr. Kundu is also the chairman of Indian Rheumatology Association. He is a member of New York Academy of Sciences and fellow in Indian College of Physicians. He has more than 118 scientific papers in index journals and approximately 800 citations. Currently, he is the visiting faculty and consultant rheumatologist of IQ City Medical College, West Bengal. I sincerely welcome you, sir, and I request you to kindly proceed over today's session. Thank you.
Okay. Thank you, Shavni, for your description. I am very humble about this. But today we have got three eminent speakers. Three eminent speakers. One is Dr. Jayanta Roy, then our famous Rabin Chakraborty, and then lastly Dr. Medha. Now, Dr. Jayanto is a very big name in neurology at this present moment in our city. He is the director of stroke medicine, INK Kolkata Institute of Neuroscience. He is the certified neurosonologist of American Society of Neuroimaging. More than 35 publications in peer-reviewed index journal, and his primary research interest is stroke in the young and stroke imaging. Today, he will discuss the neuro-inflammation and COVID-19. Just dedicating half a minute for it. When I am a man of internal medicine, went through the patient of COVID and etc. And what are the variety of features, signs, symptoms they are presenting, from headache to great abnormality. And in between that, there is seizures, stroke, anosmia, agacia, myalgia, and myelitis, encephalopathy, mental issue, whatnot. And when we went through the hypothesis, there are so many hypotheses, but the main cause of affection we will learn from Dr. Jayanta. Somebody says it is the retrograde traveling of coronavirus through the cribriform plate, through the olfactory nerve. Somebody says it is due to secondary hypoxia or damage to the receptacles. And it is also known that interleukin 6, 12, 15, and TNF alpha stimulates activate the glial cells, and that produces the inflammatory response. Dr. Jayanta Roy, we are waiting eagerly to listen from you about the inflammation and COVID. Please.
Thank you, Mr. Chairperson. Good evening to everyone, my learned senior colleagues and friends. I'm grateful to Dr. P.S. Bhattacharya for inviting me here today to deliver this very relevant and contemporary topic of COVID-19 and neuroinflammation. Are my slides visible?
Yes.
Thank you.
Yes.
Well, almost 1/3 of all COVID patients, they show some kind of neurological symptom at some point of time. It can be a very minimal headache to a very devastating coma or stroke or encephalitis. So there are many big series publications since this COVID pandemic. This is one of those publications which is from a global consortium who reported 3 most important self-reported symptoms of COVID patients. Number 1 is headache, then anosmia and ageusia, and syncope. And they also listed a number of disease conditions which can develop following a COVID infections, like an acute encephalopathy, stroke, coma, seizure, dysautonomia, meningoencephalitis, myelopathy, some different types of paresis or plagias, and sensory abnormalities. This list can be longer, and we will come up with more information on this. Well, this is another publication from our own institute. It was very recently published in Journal of Clinical Neurosciences, when we looked at different manifestations, neurological presentations of COVID patients, or patients who already had a chronic neurological conditions which were sent following a COVID infections. And they found that ischemic or hemorrhagic stroke, encephalopathy, and spine and peripheral nerve involvement and others, whereas Parkinsonism, curiously, Parkinsonism, subdural hemorrhage, seizure disorders, patients who already got intracranial space occupying lesions, they came with more symptoms when they got COVID. And once the COVID got controlled, they went back to their baseline phase. So this is another very interesting interaction between a chronic neurological condition and the acute COVID infection. This is a very common picture. We know this is the pivotal step where this spike protein gets attached to the ACE2 receptor, and that is the beginning of the entry of them into the cell. I'll come into that again in little more detail. Now, the distribution of ACE2 receptors are actually wide, very wide. It's not only the lung receptors, lung. It is the blood vessels, the other organs, the brain, and they can also be circulating inside our system. And the biophysical and structural evidence suggests that the SARS-CoV-2 spike protein is likely to bind with the human ACE2 10 to 20-fold higher affinity than the SARS-CoV-1 or the SARS-CoV, the initial one. So that's why this COVID infection is much more dangerous than the previous outbreaks. So this is the proposed mechanism of neuroinventions. There are multiple ways it can reach our nervous system. One important, which our chairperson just mentioned, that the transnasal route. It can invade the olfactory epithelium, through that to the cribriform plate, olfactory tract, and it can gain into the brain. So this nasal spread is also is known in other neurotropic viruses, including herpes. And the second is through the lung. When the lung gets involved, then they go to the hematogenous route and can reach the brainstem. And sometimes to the lymphatic system, it can reach the brain. So these are the different possible ways the COVID-19 can infect or invade the nervous system. This is a very interesting case report. I just mentioned here for your information that this paper, they found that MRI could sometimes pick up the involvement of the olfactory bulb and the olfactory tract in acute COVID infections. As we see here in the flare images, this inflammatory changes you see after COVID infections, and once the COVID got cured, they can disappear. So this is something very interesting to see, because this is a direct invasion of the virus to the brain and causing this imaging abnormalities. Now, as we mentioned initially, this ACE2 receptors, they receive these spike proteins, which are actually like a lock going into the, the key going into the lock, opens the lock and gains entry into the cell. But the actual invasion occurs through the endocytosis controlled by the endosomal proton pump and by NAADP, sensitive intracellular two-pore channels called TPC2. So this is an illustration of the same. So though the entry into the cell goes through these ACE2 receptors, but this actual invasion occurs through this TCP2 receptors into the endoplasmic reticulum. And this ACE2 is particularly concentrated in the brainstem and also in the circumventricular organs. Now, this glial cells, which are astrocytes and microglia. The astrocytes are neural cells of ectodermal origin, and microglia are innate immune cells of mesodermal origin. So these two are collectively called the glial cells. There is another group of cells called oligodendrocytes, and they are responsible for the myelination of the neurons in central nervous system. And this SARS-CoV-2 on the cells of oligodendrocytes responsible for myelination remain unclear. This is not very clear how they directly invade the oligodendrocytes, but we know that different types of demyelinating disorders of CNS and PNS have been seen after a COVID infection. So if we look at the list of different disease entities, neurological disease entities following COVID, we can see, as we also mentioned in the previous slides, that acute encephalopathy, stroke, AIDP-like illness like GB syndrome or Miller-Fisher syndrome, ADEM or acute disseminated encephalomyelitis, acute hemorrhagic encephalopathy, myalgia and myositis, critical illness polyneuropathy and myopathy, cranial neuropathy. So these are the common neurological disease entities we have seen even in our practice following a COVID infections. I have personally seen a number of Bell's palsy-like presentations in COVID patients in our OPD during the second peak of the pandemic in India. So COVID is a multi-system disease. It's not only lung, not only neurology, but it can affect any other organs. And there are many different ways it can do so. Like one is the direct invasion of the epithelium via these ACE2 receptors, and it can cause the endothelial damage, causing endothelitis, localized organ damage, widespread inflammations, and they can cause huge cytokine released, as we know as cytokine storm. And it's not only the cellular ACE2, but this virus can bind to the circulating ACE2 to cause different types of coagulation abnormalities, and they can lead to different thrombotic conditions. Another potential mechanism is direct invasion of the CNS, as we mentioned that the hematogenous route, the neuronal retrograde disseminations through the nose, or through other afferent neurons which connect the different parts of your body like lung or gut to the brain. And they all can retrogradely go back to the brain and infect the different parts of the brain, including the brainstem. And the end result of all these different pathomechanisms are inflammation-related brain disease like cytokine storm leading to encephalopathy, encephalitis, and seizure, hypercoagulable state leading to ischemic stroke or cerebral venous thrombosis, and different other neurological diseases. Now, this is again almost the similar kind of illustration where the different neurological disease can be caused by combination of different pathological mechanisms following as COVID, like direct invasion, hypercoagulable state, or post-inflammatory conditions leading to GB syndrome or ADEM or acute hemorrhagic leukoencephalitis. Now, another very interesting hypothesis which gained a lot of importance and attention during this COVID pandemic is the brain-gut axis. The movement of the virus from the gut to the brain beyond transsynaptic spread through the respiratory system is also very important and interesting. The GI tract is directly infected by the SARS-CoV-2, we know that. It is postulated that anorexia and nausea may be caused at least in part by infection of the lateral hypothalamic nucleus. And since the gut is extensively innervated by vagus nerve, so retrograde transmission of the virus through the vagal afferent pathway to the brain is also another possible mechanism for the virus to enter the nervous system. Now, this reticular activating system, COVID-19 and their interaction to the brain. We know that reticular activating system includes angiotensin 1, angiotensin 2, renin, ACE, ACE2, angiotensin receptor 1 and 2, and mitochondrial assembly receptors. So they all together cause this RAS. Now, brain RAS has similar component to that of peripheral RAS. And the degree of ACE2 expression is associated with the extent of infectivity by the SARS-CoV-2 and SARS-CoV and the SARS-CoV-2. And different ACE inhibitors or ARBs can, like ibuprofen or pioglitazone or other ARBs, can induce the ACE2 expression in vitro. So inhibitory effects are seen on the ACE2 angiotensin 1 to 7 axis by the glucocorticoids. This is one of the mechanisms how glucocorticoid works in this entire system, in addition to the anti-inflammatory process. Diabetic patients, on the other hand, overexpresses ACE2. So in a retrospective study, around 1,100 adult patients with hypertension diagnosed with COVID-19, 188 patients who are taking ACE inhibitors or ARB had a lower all-cause mortality than the non-ACE or ARB group. So this is a very interesting observation. And recently, recombinant ACE2 receptors were found to be well tolerated experimentally when they are given as an IV infusions, and they are found to be safe. But it's not yet proven to be beneficial from COVID-19. So this is one future potential therapeutic option against COVID. Now, the relevance of blood-brain barrier. We have been looking at the different pathomechanisms, how it invades the brain. So we have a blood-brain barrier, which protects our brain or interacts with the other parts of the body in health and disease. Now, cells which are infected with SARS-CoV-2 may produce type 1 interference cytokines that alert our immune system to the presence of a pathogen. Now, severe infections of SARS-CoV-2 often triggers an overproduction of pro-inflammatory cytokines, which we call as a cytokine storm when they are overwhelming. And patients with SARS-CoV-2 exhibited elevated levels of both pro-inflammatory and anti-inflammatory cytokines. This is an illustration of that. Now, interleukin-6 in particular has been documented for its potent role in immune dysregulations in the COVID-19. And in the central nervous system, IL-6 is expressed primarily by the astrocytes and the microglia and upregulated during the CNS infections and the neuroinflammations. And IL-6 was previously found to downregulate the intraendothelial adherins and the tight junctions proteins in vitro, thereby increasing the paracellular permeability of the human brain microvascular endothelial cells. This is a very pivotal step. This IL-6 is causing this blood-brain barrier disruptions, and elevation of IL-6 in the CSF is maybe indicative of the blood-brain barrier dysfunctions. Now, these neuroinvasions, these ACE2 receptors, not only the brainstem, but in the circumventricular organs like subfornical organs, paraventricular nucleus, nucleus of Tractus solitarius, and rostral ventrolateral medulla. So these are the areas where these ACE2 receptors are well populated, and all these structures are highly vascular and they lack blood-brain barrier. So this is a clever part of the virus to choose this receptor to reach different organs, including our brain, where the blood-brain barrier is deficient. An absence of blood-brain barrier, crucial for the constant monitoring of the peripheral health status, makes these circumventricular organs more vulnerable to peripheral neurotoxic molecules or invasive agents, including COVID-19. And coronavirus, as we know, that they can reach the frontal lobe through the cribriform plate. So besides direct invasion of the neural cells, it affects the neurovascular unit and CNS through the systemic inflammations. Both innate and the adaptive immune response can affect the CNS through their cellular elements and circulating pro-inflammatory factors. And the effector T and B lymphocytes enter the CNS, aiming at the invasive pathogens. So the systemic infection, which accompanies severe cases of COVID-19, was shown to proceed with substantial increase in the circulating level of chemokines and interleukins, which compromise the BBB and enter the CNS, where they encounter the defensive system represented by astrocytes and the microglia. So I know this theoretical things a little bit boring, but this is important to understand the inflammatory process inside the brain from the COVID-19 itself. This is a pictorial illustration how our normal healthy glial mechanism and how the aged brain reacts to the COVID. So in a healthy brain, these COVID infections can be very effectively dealt with this fresh and healthy microglia and astrocytes. And this is the aged brain where the astrocytes are already senescent and the microglia are also aging. So it's difficult for them to scavenge or eliminate those viruses from the brain, and the effect of the virus is overwhelming in an aged brain compared to the young adults. So I could not stop myself from bringing this very interesting concept of this happy hypoxia and how this neuroinflammation contribute to this happy hypoxia hypothesis. We know that happy hypoxia is very interesting and very baffling thing to us, how this thing happens to COVID patients. But one possible mechanism is, other than the pulmonary pathology, is the blunting of the chemoreceptors at the carotid body, because carotid bodies are also well populated with ACE2 receptors. So the virus can bind to the carotid body and they blunt the chemoreceptor response of the carotid body to hypoxia, which in turn stimulate the respiratory center, and that causes this tachypnea or the feeling of the dyspnea from the brain after a hypoxic insult. And another mechanism is this involvement of the tracta solitarius. So this picture shows there are different afferents to the brain, from carotid body through the glossopharyngeal nerve, which goes to the brainstem. From the lung baroreceptors, it goes to the brainstem through vagus, or our gut receptors. They can retrogradely get involved through the vagus and they reach the brainstem. The brainstem is the area which gets affected by this COVID virus, and they alter the different receptors in the brainstem, including the respiratory neurons, and they blunt the effect of the hypoxia to the respiratory neurons. So the patients become severely hypoxic without any feeling of dyspnea or any tachypnic responses to that. So this is the picture which I just described, and this is how the afferents, different afferents, take this virus to the brainstem and involves different important nuclei in the caudal brainstem, responsible for this respiratory drive. And another very interesting hypothesis is the silent hypoxia in COVID-19, a gut microbiota connection. This is a hypothesis which gained importance recently. And if you see here, a patient who is hypoxic, but not due to COVID, but some other disease, they have a different gut microbiota, and the interactions with this gut microbiota and the brain is different. I'm not going to the detail of that. But if you look at the same in a COVID patient, since they invade the gut and alters the gut epithelium, they disrupt the intestinal integrity and changes the gut microbiota, causing gut dysbiosis. They can initiate a cascade of different chemical reactions, and that can alter the brain sensitivity to hypoxia indirectly, and causing this happy hypoxia or silent hypoxia in COVID. So this is a very interesting concept. So coming to the last part of my talk, that is COVID-19. These are the acute conditions we have been talking about. But three important disease entities are of interest to follow up in long term following COVID infections, like Parkinson's disease, multiple sclerosis, and narcolepsy. So a possible neuronal injury that in turn might trigger the synucleinopathy cascade. We know that in Parkinson's disease, the myenteric plexus in the gut, which is connected through the vagus nerve to the brain, has play a major role in transgression or retrotransgression of this synuclein to the brain, deposition inside the brain, and causing Parkinsonian syndromes. This synucleinopathy cascade can be stimulated by COVID-19 and can cause Parkinsonian syndromes, but in coming years, we'll be understanding this impact of the disease in the long run. And multiple sclerosis, while intestinal dysbiosis and changes in the intestinal permeability are increasingly recognized as modulators of neuroinflammatory mechanisms through the so-called gut-brain axis. A number of chronic neuropsychiatric disorders are also being increasingly recognized, and we have seen different other pandemics like schizophrenia cases after a Spanish flu, depression and anxiety and PTSD after SARS-1, or Parkinsonism symptoms after H5N1 pandemic has been seen. Stroke is also not an exception. There are different mechanisms of stroke, and starting from cardiovascular injury, prothrombotic conditions, inflammations, and interestingly, the pre-existing stroke risk factors, including these plaques, different parts of the body can get activated, and they can cause stroke. This is the different mechanisms. And stroke can be initiated by different respiratory pathogens. We have seen that during influenza pandemic, but COVID has got a higher chance of causing more stroke compared to the other respiratory viruses, including influenza. And it has poses a big challenge in the stroke care all over the country, including other parts of the globe. These are the different publications we surveyed during this pandemic. This is a publication from our COVID study group in India, which seen that the workflow metrics of the stroke management has been greatly affected by this pandemic, and the stroke treatment got affected because of that across the globe. And so the basic challenges to maintain the neurological and the stroke emergency care following during this COVID pandemic, and the American Stroke Association has come up with this protected code stroke protocol. I'm not going to the detail of that, just for the sake of your interest, that we are now running this protected code stroke protocol all over the world to manage a stroke patients in the middle of a pandemic, to provide them the best of the stroke care despite different logistic challenges during this COVID pandemic. So thank you very much for your attention.
Thank you, Dr. Rai. You are absolutely in time. I think the question and answer session will occur at the end of the seminar. Thank you. Now, for the second speaker, I want the introductory slide, Sayani. Dr. Rabin Chakraborty.
Shani, please place the second Dr. Chakraborty slide. Arup, that is placed.
Where it is, I can't see. Oh, okay. Now, for the introduction, I can only say Dr. Rabin Chakraborty is an example of himself. I need not explain it. Dr. Chakraborty is a renowned cardiologist, everybody knows, in India and South Asia. He is the senior consultant, interventional cardiologist and electrophysiologist, now working as a senior specialty in Medica Super Specialty Hospital. His area of specialization are many, and with special reference to diagnostic coronary angiogram, right and left heart study for valvular heart disease, cardiomyopathies, and congenital heart diseases. He has several publications and chapters in national and international journals to his credit. Now, we will learn many things about the myocardial injury and COVID from Dr. Rabin Chakraborty. I do not know, many of us do not know whether this myocardial injury is due to systemic inflammatory response or immune system disorder or related to plethora of ACE2 inhibitor present in the heart, just like in neurology, Dr. Jayanta was telling it. And there we see the myocardial acute injury, chronic injury, and a chain of vasoconstrictive effect like thromboembolism and etc. Dr. Rabin Chakraborty, please.
Yeah, thank you, Arup. This is very nice. So I'll just share my screen.
Thank you.
So it's great to be here again with Partho, and so I can't say no whenever he requests me to deliver a talk, and perhaps for a number of times I always agree to that, and this is one of those occasions when I agree to participate in this meeting. The reason is, of course, to share my views, knowledge, and much more than that is for us to learn from others as I'm learning. Even Jayanta's talk was really great, and I really learned. So coming back to COVID and heart and perhaps heart injury, I think COVID-19 is an ideal example where a biological abnormality of a microorganism caused an epidemiological catastrophe. Seldom we do come across such kind of problem. When we do come across biological abnormalities in number of microorganisms, perhaps every now and then, but seldom it does cause an epidemiological, not only it is a pandemic catastrophe. And we all know that SARS-CoV-2 is basically a kind of RNA virus. We measure 4 important proteins around its envelope: spike protein, genome right RNA, nucleocapsid, envelope protein, and membrane protein. And the key entry point, the key entry receptors, as Jayanta has mentioned, and you also mentioned in your initial introductory remark, that ACE2 is an important component of causing all these problems. So I'm not getting into the detail of ACE2, but COVID-19 caused by a strain of coronavirus, which is SARS-CoV-2, has become a global pandemic that has affected the lives of billions of individuals. Extensive studies have revealed that SARS-CoV-2 shares many biological features of SARS-CoV, which is primarily a zoonotic virus that caused 2002 outbreaks of severe acute respiratory syndrome, including the system of cell entry, which is triggered by binding of the vital spike protein to angiotensin converting enzyme 2, or ACE2. And if you look at the disease, the COVID waits for no one. It has its own pace of growing and a own pace of creating trouble for the physician, for the community, for the healthcare workers, for the government, for the administration, for every category of human civilization is affected by these problems. Because it's a slow, extended plateaus with rapid, unpredictable transition over hours and prodrome. That's the reason we get sort of, the COVID first wave, then second wave, then third wave, and we don't know how many waves are there. And probably there are small wavelets. And it does cause silent hypoxia, which at times get manifested by tachypnea. There's struggling for oxygen. There could be respiratory failure, and there could be even catastrophe, including death. And as has been mentioned very rightly, that there are neurological problems. There's hypoxic failure, and there are kidney injury, hypercoagulability, liver injury, as well as sudden cardiac death. And if you look at this slide, it clearly shows that you got a mild infection on one side, and the other side is severe infection, and it's very unpredictable. You don't know who is going to get affected by what, which way, and by what mechanism. So it's very complex, and that is a problem, that we do not know which organ will be primarily affected. But if you just summarize it, probably it is like this: incubation, followed by viremia, and then it starts the organ dysfunction. The organ dysfunction is completely different as compared to other disease process. there could be hyperinflammatory status, there could be direct toxic injury, there could be immunological mechanism, there could be something else which is coming in and causing such damage. And that is getting manifested clinically by temperature like fever, cough and headache, and sometimes with thromboembolic manifestations, sometimes by acute coronary syndrome, sometimes cardiac arrhythmia, and so on and so forth. But this is a slide which is basically an X-ray has been taken during Wuhan infection of a patient, where you can see clearly that there is a significant chest air abnormality with cardiomegaly. And this is one such example where the COVID has actually created a problem, because the COVID has a significant affinity called broad tissue tropism. The SARS-CoV-2 preferentially infects the lungs and respiratory tract, which we all are aware of. There's a reason why the pulmonologist, critical care specialists, they come into the picture. But it does cause diverse range of extrapulmonary manifestations, including cardiovascular disease, neurological disease like stroke, seizures, liver damage, gastrointestinal problem, kidney problem, renal dysfunction, and systemic hyperinflammation induced by viral pneumonia is likely to have an important role in the development of these varied manifestations of COVID-19. And numerous studies have also reported histological evidence of such viral infection of non-respiratory organs such as heart and other organs. And if you look at COVID-19 and heart injury, it is very interesting that if you go back in 2019, the first sign, this is a very, very fantastic sort of statement made by Aaron from Massachusetts General Hospital of Boston. And he said that the first sign of heart damage was in the blood. In early case reports from Wuhan, China, where the novel coronavirus emerged, there's an unexpected number of patients they did find were hospitalized with a respiratory infection, had elevated levels of cardiac troponin, which is an important marker of myocardial injury or heart muscle. Next came the echocardiographic sort of image suggesting functional abnormality in many patients. Later on, there was further investigation like cardiac MRI and other investigation. So it progressively became obvious that myocardial injury heralded a poor prognosis for patients hospitalized with corona infection. And if you look at this slide, it basically tries to highlight the interaction of coronavirus infection with cardiorespiratory or cardiovascular system. The primary target may cause hypertension, tachycardia, cardiac arrhythmia, brady, tachy, and sudden cardiac death. And the pathophysiology of this is SARS-CoV-2 binds ACE2 sort of receptor, which is also expressed in the heart. And there is increase in pro-inflammatory cytokine and systemic inflammation. And at the same time, there could be significant secondary comorbidity. For example, the CVD is common in this group of patients. And there you can have systemic inflammation, which may lead to increased risk of coronary plaque rupture. There could be procoagulant effect of systemic inflammation, which may increase the risk of stent thrombosis after intervention or earlier intervention. So patients with pre-existing cardiovascular disease are equally at high risk for adverse events of infections with respiratory virus. Viral infection may contribute to unstable chronic cardiovascular disease, which is primarily due to imbalance between metabolic demand and cardiac reserve. And the viral target is endothelial cell. That is very important, the crux of whole understanding, because we have the data to substantiate the findings from the number of case series. There are huge number of sort of meta-analysis. Out of those meta-analyses, the 8 paper are extremely important, which suggested that SARS-CoV-2 can infect endothelial cells directly, which can lead to inflammation in the endothelium. And given that endothelial cells are an important component of every organ and have a high level of ACE2 expression, inflammation in the endothelium caused by infection with SARS-CoV-2 might actually underlie the diverse clinical manifestation. But we actually took more than 6 months or maybe 8 months or 10 months to understand that COVID is basically a vascular disease, a vascular problem, not primarily the virus causing parenchymal injury. It does, but primarily it is the endothelium, which is culprit, whatever may be the organ which is affected by COVID-19 infection. And if you look at the spectrum of cardiovascular syndrome, it has been shown, published last year, that from acute coronary syndrome, like this, where the artery is blocked, you can see there could be acute coronary syndrome, stable or unstable. There will be acute myocardial injury causing obstructive coronary artery disease, and this is the finding. And there could be cardiac arrhythmia, there could be heart failure, there could be pericardial effusion. In fact, I'll show you a slide which is nicely shown an athlete having a pericardial effusion like this, an echocardiogram image, and thromboembolic complications like in this case where there's blood clotting the pulmonary circulation. So it could be myocarditis, cytokine dysregulation, it could be stress cardiomyopathy. We know that patient with a lot of stress can actually present to cardiologist in emergency with something similar to Takotsubo cardiomyopathy. So clinical studies have also reported an association between COVID-19 and cardiovascular disease. We have already discussed the pre-existing cardiovascular condition is again an important factor which actually may get complicated with COVID-19 infection. Because COVID-19 infection can also, myocardial injury can cause arrhythmia, can cause acute coronary syndrome and venous thromboembolism. And also, there could be drug disease interaction affecting patients with COVID-19 and comorbid cardiovascular disease, because there are a number of drugs which are being commonly used in COVID infection. Some of those drugs may also have got a potential cardiovascular side effect. So if you really go through the stages in phase 1, asymptomatic or mildly symptomatic with headache, fever, myalgia, and diarrhea. There could be other manifestation. Phase 2, pulmonary phase, hypoxia, dyspnea, and other kind of thing. And phase 3, where the host response phase characterized by massive elevation of inflammatory marker, which we know, I'm sure Patwa and others probably know better than me, but that is what exactly it is. The individual case fatality rate of patients with cardiovascular disease is 10.5%. And there's a nice paper published from the Oxford group, Radcliffe Hospital group. They have actually shown the incidence of cardiovascular involvement could be from 4% to 44%. And out of these maybe 17% can have myocardial and pericardial disease, and maybe another 10 to 15% can be have cardiovascular coronary related problem. And 10% may have associated comorbid related condition. The case fatality rate could be as high as 7% and sometimes can go up to 10%. And this is the primary 6 mechanisms by which myocardial injury may affect in COVID-19. 1, direct viral toxic effect. B, immunologically mediated myocarditis, which eventually may lead to cardiomyopathy. There could be endothelitis or endothelitis. There could be prothrombotic thromboembolic features like pulmonary thromboembolism, cardiac thromboembolism, cerebrovascular thromboembolism. There could be stress-induced cardiomyopathy like Takotsubo cardiomyopathy, and of course, acute coronary syndrome. And all of these or some of these eventually, if being treated, may actually continue as chronic cardiovascular disease. So to summarize, if you look at this slide, it shows that these are the possible causes of myocardial injury in COVID-19. And COVID-19, because of inflammation, because of viral injury, because of myocarditis, because of arrhythmia, heart failure, direct myocardial injury. There could be chronic myocardial injury, like stable coronary artery disease. There could be pre-existing cardiovascular disease which may affect. There are patients with other conditions like diabetes or other things may get affected. And also, it can cause hypotonia, hypertension, tachycardia. There are autonomic system affecting cardiovascular system. So it is important for us to recognize all these kind of things. This is a slide which is basically an athlete, and he had actually COVID infection improved, but after that was getting some kind of shortness of breath. So clearly he went to his pulmonologist and his lung was okay, but did not, saturation was maintained. Even after 6 minutes walking test, saturation did not drop, but he continued to remain breathless. And then they did an MRI, which showed a pericardial effusion, which you can see outside the heart is a shadow, and that suggests that he has moderate pericardial effusion, which is not responding to usual treatment. So acute myocardial injury, as evidenced by elevated levels of cardiac biomarker like troponin, electrocardiogram abnormality, it was observed in 7 to 20% of patients of COVID-19. Cardiac injury was also found to be an independent risk factor for in-hospital mortality. That is the reason why it determines the outcome of clinical outcome of the patient. That's why it is important for us to talk about cardiac injury in COVID this evening. There's another study confirmed this finding and reported that the rate of death in patients with elevated levels of cardiac troponin was as high as 37.5%. I have to say here that it is very important for us to remember and recognize many of these cardiac injury patients may not have symptoms. They could be just an elevated cardiac troponin. And if you happen to do an echocardiogram, you may find some abnormality. And if you happen to do some cardiac MRI, you will find some abnormality in this group of patients. So it is interesting. Furthermore, this further studies have also shown that markers of myocardial injury were predictive of in-hospital mortality in patients with COVID-19 infection. This also gets complicated and compounded in presence of advanced age, in presence of diabetes, associated kidney disease, alcoholic, and immunologically compromised people, or even malignant patients. And we have got evidence to prove that there's evidence that this SARS-CoV-2 can get into the cardiac myocyte, and then that is what is called cardiac myocyte actually becomes very complicated, often being termed as cardiosphere. And this cardiosphere, this has been proved by a chap from Germany, and they have found that this group of patients, they have actually collected the data from endomyocardial biopsy in some patients and largely from the post-mortem autopsy series, and they found the myocardium cell sort of geometry, the anatomy gets distorted in COVID-19 infection. So clearly there are histopathological changes which are the predictor or predecessors of long-term myocardial injury in COVID-19 patients. So that is the reason why even patients after recovery from COVID infection, they come back to us, go back to pulmonologist, and then they complain of some kind of abnormalities, which may be the cause, and the cause of which could be the residual damage of myocardium and pulmonary tissue. And as I said, that acute coronary syndrome, we can get ST segment elevation myocardial infarction of COVID-19. It has been found. This is a very interesting study. This is a group from Boston, actually, from Beth Israel Hospital, and Deepak Bhatt, who is a very close friend of mine from Beth Israel Hospital, Harvard. He presented the data, and then it was later on the patient actually taken up for angiogram, very small number of patients. And then they found that, well, they got very advanced atherosclerotic process in combination with systematic inflammation. The mechanism of this is because the ACS might cause plaque rupture, coronary spasm, there's a microthrombi, and associated with the systemic inflammation and cytokine storm. And because of that, we know that the atherosclerotic plaque is the cornerstone, what is called unprotected atherosclerotic plaque is the main cause of acute thrombotic coronary syndrome, and that gets triggered by COVID-19 infection. That has been nicely or elegantly demonstrated by this team from Beth Israel as well as from Columbia Group. And Deepak actually finally summarized the data and presented in one of our meetings. Because the cardiac pathology associated with this, there could be, this is the heart, there could be focal pericarditis, there could be endocardial thrombosis, there could diffuse macrophage infiltration, there could be small vessel thrombi, there could be lymphocytic myocarditis, or even the right ventricle may also get affected. There's one more paper. This was from Dr. Basso. Dr. Basso is Aaron Basso from Mass General Hospital, Boston. But later on, we also came across with some other papers showing that there is actually cardiac myofibrillar defragmentation. So there is a fragmentation of the cardiac myofibril, causing further injury to heart muscle. So as I said, there could be microvascular dysfunction. There could be inflammation and apoptosis, which is a very important component of pathological process of myocardial injury, heart injury in COVID. So, and there is a sort of very elegant sort of slide which they have shown the normal the heart, and then progressively they have shown that how the apoptosis actually cause myocardial injury, and that is an important component or pathological component of heart injury. Arrhythmia and sudden cardiac arrest are common manifestations of COVID-19. Heart palpitation have been reported, and we did not know. We thought that it is probably secondary to hypoxia or secondary to pulmonary infection or inflammation, or maybe other organ inflammation, or could be electrolyte imbalance, because as it happens commonly in critical care unit. But later on, it has also found, well, there are the causes, but at the same time, the cardiac muscle itself could be electrically abnormal, and that can cause cardiac arrhythmia, which is again a very important point to remember. The exact contribution of COVID-19 to cardiac arrhythmia remains uncertain, given that atrial and ventricular tachycardia and fibrillation can be triggered by myocardial injury or other systemic causes like fever, sepsis, hypoxia, electrolyte abnormalities. Even the patients with acute coronary syndrome can also get cardiac arrhythmia. Myocarditis can also get cardiac arrhythmia. So there are so many mechanisms. Drug interaction can cause cardiac arrhythmia. There are so many mechanisms which can cause cardiac arrhythmia in COVID patients. And COVID-19 infection and thrombosis is another important parameter which you need to recognize. So acute myocarditis, cardiomyopathy, inflammatory injury, immunological injury, acute coronary syndrome, and cardiac arrhythmia, as well as thrombotic like COVID-19 infection and prothrombotic stage. Severe COVID-19 can be complicated by significant coagulopathy that likely manifests in the form of both microthrombosis and the sort of venothrombotic thromboembolic manifestation. The key factor of such coagulopathy is again a cytokine storm that actually triggers the coagulation cascade leading into the thromboembolic manifestation. And this is the coagulation cascade. That COVID-19 affects coagulation cascade, that you can see this is a extrinsic factor, intrinsic factor, which we are quite familiar with that. SARS-CoV-2 actually jeopardizes this coagulation cascade protein, as well as there is a leukocyte recruitment leading into inflammation and degranulation. And it goes down along with interleukin-1 and interleukin-6. And then furthermore, it goes down, eventually causes thrombosis. Very complex mechanism, but that is in short, it has been found in mouse model. Thromboprophylaxis has also been found to be an extremely important part of treatment in COVID-19 infection. In the absence of contraindication, we recommend anticoagulant thromboprophylaxis over no anticoagulant thromboprophylaxis, particularly for acutely ill hospitalized patients and critically ill patients with COVID-19 infection. In acutely ill hospitalized patient COVID-19, suggest low molecular heparin or fondaparinux, and later on we also give NOAC, which is an important component of therapy. So the prognostic marker of COVID-19, that is a very important. We know that inflammatory marker like CRP, ferritin, D-dimer, prothrombin time, high plasma level of pro-inflammatory cytokine, and the presence of endothelial injury, particularly significantly elevated von Willebrand factor and factor 8 level. This is very important. Although I have to say that at the moment we do not have enough data to guide clinical practice for VTE diagnosis, but we know that VTE is an important manifestation of cardiovascular manifestation, vascular manifestation, in particular in COVID-19 infection. So we know that in COVID-19 we got hyperinflammatory stage, and patients population could be a relatively high risk group. The disease-specific factor, which is related to COVID-19, and endothelitis or endothelial dysfunction, all these together causing procoagulant or thromboembolic manifestation. In addition to that, sometimes which is being not known to the clinician because we don't see, we know that there could be microvascular thromboinflammatory response, loss of vascular endothelial cell protection, as well as the other kind of thing. Again, endothelial cell dysfunction, microthrombus, and RBC condition could be an important component of such therapy. So terminal arteriole could be affected. The neutrophil adhesions and aggregation could be affected, secondary to inflammation. There could be impaired blood flow at the capillary level because of sludging of RBCs, neutrophil, and platelet, leading into this manifestation. And in medically ill patients, we know somebody very old, somebody elderly patient with other manifestation lying in the critical care unit is prone to develop thromboembolic features. So coagulopathy is an important component in COVID-19 infection, and we need to remember. And there's a nice survey has been conducted, and which shows that a current VT management practice for hospitalized patients with COVID-19 and brings to attention the need for well-conducted epidemiological studies and clinical trials. So this is a slide which summarizes that. We also need to remember, perhaps we're talking a lot of vaccine, but vaccine may also have, at times may cause thrombosis, at times may cause thrombocytopenia syndrome, which one should be aware of. Kawasaki disease has also been reported, although the children are thought to be affected for primary Kawasaki disease, but it has been shown that even in adult population, they presented like a Kawasaki features of vasculitis and aneurysmal dilatation of blood vessels secondary to COVID infection. The series of cases being reported from United Kingdom, they have shown that Kawasaki-like features has been reported in their series of COVID infection. And finally, heart failure. Heart failure is an important component of COVID-19 infection, and it varies from 13 to 33%. It is more so in patients with a previous heart failure. It's more so in patients with pre-existing cardiovascular comorbidities, more severe in COVID-19 infection. Therefore, we do find some patients of COVID-19 they have elevated BNP or pro-BNP. Chest imaging may show that lungs are suggestive of COVID, but there is associated heart failure features. There could be cardiomegaly, bilateral pleural effusion, and there could be echocardiogram which showed left ventricular dysfunction. There could be drug and disease interaction. We know that people are very anxious initially that about ACE and ARV usage in COVID patients because it's a ACE2 mediated kind of injury, ACE2 mediated pathological abnormalities. But later on, this is the data which initially came from Spain and Italy. But later on, we found that there is really there's not much evidence today to prove that if you do not prescribe ACE blocker or ARB antigen receptor blocker, you can actually stop COVID. There is no such data. So that has been completely excluded because there's a different mechanism altogether, which I believe Jayanta has touched upon. And this is a very complex slide. I need not getting into that. ACE2 as a part of RAS is a complete. So basically, COVID is a disease where there is down regulation of ACE2. So AR1 and hydroxychloroquine has got no relevance today. Remdesivir, lopinavir, ritonavir has tried, but I think off late the data is not very convincing. So the lesson that we learned that there is a high mortality of cardiovascular disease patients infected with COVID-2. SARS-CoV-2 N3 receptor ACE2 is upregulated in the disease heart. There are now multiple evidence of direct cardiac infection, and most patients with acute heart failure is not frequent, is very common. And there's a management algorithm of heart failure in COVID-19, and you have to follow accordingly. So to summarize, so coronary heart disease I've already covered. This is heart failure. So I'll just probably come back to my last slide, that heart may be affected in a number of ways in COVID-19 infection, directly and indirectly due to high inflammation and cytokine storm, acute coronary syndrome, heart failure, cardiac arrhythmia, sudden cardiac death, and drug disease interaction are important. Pre-existing heart disease and the risk factors are again important to determine the mortality and the duration of hospitalization and complication while in the hospital. Hypertension, diabetes need special attention. Although COVID works through ACE2, but ACE1, ACE receptor antagonist and ARB should be continued. Thromboembolic complications are of paramount importance. Finally, COVID-19 is a vascular disease and should be treated accordingly. Thank you very much for your attention.
Thank you. Thank you, Dr. Chakraborty. It was a nice lecture. It was a nice lecture. I think everybody has been benefited. After this, the question answer session will be at the fact end. Again, I'm telling. After these two erudite speakers, we have reached the last part of today's CME. Our doctor is another speaker, beautiful, the Medha Bargaje. He's a professor of respiratory medicine, but he is really interested in rehabilitation of pulmonary rehabilitation. And it is the center project implemented at the Department of Respiratory Medicine at Bharti Medical College, supported by CIPLA Foundation with a vision of the patient's well-being for post-COPD or COPD cases, post-COVID or COPD cases. He is interested to that. She is the nodal officer for DOT Center under NTEP in Bharti Hospital, and her area of interest is COPD, respiratory rehabilitation, especially. We'll learn from her that the COVID rehabilitation and tuberculosis. I have only one thing to say. As a rheumatologist, what I have heard, the post-COVID rehabilitation has been divided by many facets. There are so many issues. One is commonly the musculoskeletal or physical issue. The cardiopulmonary, the pulmonary part will be dealt by Dr. Bargaje. The psychological issue, the anxiety, depression part. Then the nutritional issue. Then activity of daily living. attention and memory issue, and swallowing problem. These 7 things has been published by AIMS Patna, the rehabilitation of COVID. But we are concerned about Dr. Bargaje's description of pulmonary rehabilitation. Dr. Medha Bargaje, please.
Thank you, sir.
Yeah.
Sally, could you please start the PPT?
Shani, start the PPT.
Is it
Thank you.
visible, sir?
Yeah,
Okay.
visible.
Can you start the slideshow? Yeah, thank you. Good evening, all. Thanks, Dr. Bhattacharya, for giving me this opportunity. Like Sir has said, I've been involved in this post-COVID rehabilitation project, which is supported by Cipla Foundation in our Bharati Hospital. Pune being the hotspot for COVID during first wave and second wave, within few months we realized that we need to start post-COVID OPD and rehab center also. Thanks to Cipla Foundation, they supported us for equipment as well as HR. Sally, could you show the next slide? As you all know, pulmonary rehabilitation is comprehensive multidisciplinary intervention. And as Kundu sir said, yes, Cipla supported us for cardiorespiratory physiotherapist. In our team, we have got social worker, project coordinator, nutritionist, and counselor. Under this project, for last 9 months, we have been giving free rehab to post-COVID patients. What I'm going to share with you is SOP we have prepared and problems or challenges we face during implementation of this rehab. So as per our SOP, our patient goes through pulmonary department seen by pulmonologist. Then patient is referred to physiotherapist. Physiotherapist assessment is done, and then the rehab program is started. Siley, next slide. So let us begin with these 4 patients. I have taken this as representative of various groups I have come across in last 9 months. So first I'll introduce Mrs. Kamla. She's 56-year-old, post-COVID patient. She was admitted during first wave for almost 40-50 days in ward. Her scan score was 18. She was treated with oxygen, remdesivir, steroids, and heparin. Our second patient, Mr. Sohan, 60-year-old. He has got past history of COPD, diabetes, hypertension. His HRCT score was 12 and was treated with oxygen, remdesivir, steroid, and heparin. Our third patient, Mrs. Chitra, who was post-TB, hypothyroidism, diabetes, hypertensive, and during COVID second wave, she was not admitted but advised home isolation. And our fourth case, Mr. Karan, who along with his all family members had COVID during second wave and was treated with oxygen, remdesivir, steroids, and heparin. Now, these were the first 4 patients presented to our OPD. And as per the criteria for PR referral, they had oxygen support during hospital stay. Their quality of life was impaired. Few of them had hypoxemia, comorbidities. So during their interaction with them, we decided, yes, they need rehab. Sally, next slide. So as far as Kamla was concerned, Definitely, she had oxygen support and HRCT score was very high. Regarding complaints post-COVID, she was complaining of weakness and mild desaturation. At rest, her O2 saturation was around 95, 96. And after doing some work, she used to say the saturation was around 92. Regarding Mr. Sohan, he had comorbidities. Uh, Typical COPD patient, he used to take inhalers whenever he used to think it is necessary, not as per our prescription. His HRCT score was 12, and obviously post-COVID, he was complaining of dyspnea, and with comorbidities, we said yes, he requires rehab. Mrs. Chitra, the third case, she was home isolated. So a few months, she was taking rest at home, and then after the lockdown was over, she came for follow-up. So that time we realized she is having weakness, she is having comorbidities, and she was complaining of joint pain. So yes, we thought she is candidate for rehab. Fourth case, Mr. Karan, actually the whole family was like candidates for our rehab. So here maybe I should start with challenges with this. Mr. Karan himself was on home oxygen after discharge. His son also required oxygen during hospitalization, but after discharge, he was okay, didn't require any oxygen. Karan's daughter-in-law, she was pregnant when she got COVID, and Karan's wife, she got COVID but was advised home isolation. Frankly, out of this four, definitely Karan and his son required rehab. But then Karan said, I don't know how am I going to go for this rehab because we have got so many problems at home. Sally, next slide. After interacting with these patients and finding out about their complaints and suggesting them rehab, we had to look for exclusion criteria also for this rehab as per our SOP. So we ruled out whether any of them have got some of these conditions like maybe unstable cardiovascular parameters or thromboembolic phenomena. And then we said, fine, we can go ahead with rehab. Sally, next slide. Now, always as per SOP, we need to find out how much exercise, what kind of exercise we need to prescribe to these patients. So all these enrolled patients, they undergo pre-assessment before starting the program. One is 6-minute walk test and second is quality of life. These tests are repeated at the end of 2 months. So coming to SOP, our rehab program was for 6 to 8 weeks, twice a week. We discussed, 6-minute test was to assess the exercise capacity. Now, few of these patients were able to do 6 minutes, but like Mr. Karan, he was on oxygen. So definitely we could not do 6 minutes in this patient because in the initial phase of our rehab center, we were not very confident about 6-minute test with oxygen. After 5-6 months, we realized we need to get some idea about their exercise capacity on oxygen. So then slowly we started 6 minutes. But initially, these patients who were on oxygen either at the time of discharge or at home, we were not doing the 6-minute walk test. So obviously we didn't have the pre-test values of 6 minutes for few of these patients. The other one was quality of life. Obviously, after finding out quality of life in some of these patients and interacting with them, we realize there are many issues. Like in previous 2 lectures, we have come across few of these patients, they have got stress. The stress is related to disease also. The stress is related to lockdown also. The stress is related to financial problems also. So that is how actually we started added counselor to our team and started counseling sessions also. At the same time, we realized during pre-assessment, many of these patients have problems as far as nutrition is concerned, because typically Bharti being one of the COVID dedicated center, we realized during first wave that I myself have done COVID duties. The typical scenario in our COVID ward used to be we had ward almost of 100 beds, and during typical lockdown we had problems with food delivery. With COVID, neither the relatives were allowed to enter the ward, but sometimes we used to allow them to give tiffins. But with lockdown, that also was a bit difficult. Typically, many of these patients were having deranged blood sugar, either because of COVID or because of steroids or because of maybe pre-existing diabetes. So diet was a big issue. Post-discharge, when we interacted with these patients in post-COVID OPD, we realized many of them have put on weight, either maybe because of steroids or maybe because of uh, nutrition, which we couldn't take care during COVID period, COVID hospitalization because of various problems. So that is how we included nutritionist also. So within 9 months, initially our team consisted of a physiotherapist, project coordinator, social worker, and data entry officer. Within 2 months, we interacted with CIPLA Foundation. Thanks to them, they allowed us to include a nutritionist and counselor in our team. Sally, could you go for next slide? Now, after counseling Kamla, Chitra, Sohan, and Karan regarding rehab, after giving them idea about this 8 weeks program, uh, Mrs. Kamla was eager to start the program. I realized the factors for this compliance were first, the family was educated. She realized that she has to undergo this rehab if she wants to lead normal life. Her brother-in-law is doctor, so somewhere actually his interaction with the patient also helpful. That helped, that reduce our difficulties in counseling. So Kamla happily started coming for rehab. She completed our 8 weeks program at center. So with Kamla, we didn't have any issue of compliance because of her own willingness, her brother-in-law's support, who is doctor. Regarding Mr. Sohan, as you know, he had COPD, diabetes, hypertension. One of the problem we faced, he was staying alone. He didn't have any relatives with him. So transportation coming to center was a big problem for him. At the same time, he wanted to come, but we said we want some attendant to accompany you because of his comorbidities. We didn't want him to come alone. So family issues were there, nobody to accompany him, and we were a bit reluctant uh, to welcome him in the center if he was going to come alone. As far as Mrs. Chitra was concerned, her problem was different. She was ready to come, but her family members were a bit reluctant because during lockdown, they were sitting at home. So financial issue was there. So though we were giving free rehab services, her son's typical response was, I have to go for my work daily. So who is going to accompany her? Her husband was not very willing to accompany her daily. So, and another problem was uh, being uneducated housewife. She was not very confident to come alone to center. Now, after going through these problems, around, 2-3 months after starting our rehab, we said only at center sessions are not enough. So we started online sessions to solve this challenge, this problem. So Mrs. Kamla was very happy. Once a week, she used to come to center. Once in a week, she used to attend the online sessions. Mr. Sohan, even with online session, there was a bit of problem because with COPD, diabetes, hypertension, he was staying alone. So we were also not very happy to give online sessions. He used to desaturate. So we were worried if something happens at home when during session, who is going to take care of that? So there also, again, we faced problem with even online in case of Mr. Sohan. With Mrs. Chitra, though we gave her option of this online, she said, I don't know, I'm not very comfortable with mobile. Her husband was okay with online session, but he said, I also can't handle this online thing, how to log in and how to go ahead with it. The son was again same problem. He said, I'm going for my work. So 9 to 4, he was busy. So again, Mrs. Chitra's problem we couldn't solve. As far as Mr. Karan, he was very happy with online because uh, his son was okay with it. His daughter-in-law who was pregnant, she said, I can manage that. So Karan with his wife, they started attending the online sessions. Now the typical program for this patients were, Siley, could you please go for the next slide? Warm-up period, aerobic training, resistance training, cool down, and education. Now another challenge we face, whenever patient used to come for offline or at center session, we could follow all this proper warm-up period, aerobic training, all sorts of training. But online, because patient used to be at his home and we used to take, our physiotherapist used to take session from hospital, from physiotherapy department. So we used to go up to maybe some of upper extremity, lower extremity, a bit of breathing exercises. But regarding resistance training and aerobic training, there used to be restrictions or limitations. Regarding our fourth patient, Mr. Karan, he was very happy because another plus point with him was for online session, his daughter-in-law, who was pregnant at that time, she is doctor. So she could understand some of these things and could solve some of these problems. And hence, with Karan, the online and offline sessions were very successful. As far as Mrs. Kamla, she also attended both the sessions. Again, the plus point was her compliance, and one of her family member is doctor. Sohan, we could not solve his problem. In between, he got admitted again for COPD exacerbation. And that time we realized patients who had only COVID without comorbidities, it was easy, their improvement was visible. But typically post-COVID patients with pre-existing problems, especially COPD and ILD, it was difficult to convince the patient also, and it was difficult to show them the improvement also. Still, Mr. Sohan himself was very eager to go ahead with sessions, but because of these limitations of somebody, companion, we couldn't take his sessions. As far as Chitra is concerned, she attended few sessions, and like I told you, because they were not comfortable with online, no, they were comfortable in coming because she alone couldn't come. So there was the problem we couldn't solve. Still, during her monthly follow-up for hypothyroidism, hypertension, and diabetes, we counseled her again. The patient understood she needs rehab. But when we interacted with son, now he came out with another problem. He said, Madam, you are saying this exercise helps, but what I have been observing is like she is not used to do any exercise for all these years. So when she comes and does the exercise, her breathlessness increases and she feels more weak and she can't do her household chores. We were a bit surprised, and after interacting with the patient, our social worker found out her flat was on 4th floor. They didn't have lift. So whenever we used to tell her to come, she used to walk down, then used to take auto, and then again used to walk a bit for coming to her OPD. So she used to get exhausted. Same thing while going back after doing a bit of exercise, she used to climb all the 4 stairs and she used to get exhausted. So the relatives were not very happy. They never understood like she needs a bit of relaxation after exercise. At the same time, we couldn't solve her problem of not having lift in her building. Sally, could we go for next? So these were the challenges like I discussed. As far as Kamla is concerned, it was very easy. As far as Sohan is concerned, after one admission for acute exacerbation of COPD, his distant relative, he came, he said, we counseled him, and then he said, yes, I understand the problem. So now I'm going to admit him in old age home. And old age home, they have MBBS doctor, so even attendant. So now he will be able to attend your online sessions. So if now in these 4 cases, we want to enumerate the challenges, Siley, can you go to next slide? Definitely scheduling the appointments, getting the patients to online or offline sessions. During second wave, we had many patients whom we couldn't give appointment. Then many of our patients, though they understood they need to come for rehab, they were afraid of coming to hospital, which was a COVID dedicated hospital. Uh, and the fear of getting COVID reinfection stopped them from coming to rehab sessions. At the same time, we realize, especially with female patients, it is very difficult to solve some of their problems, whether COVID, post COVID, whether comorbidities or not. Typically, all the females after COVID, if they are not on oxygen, they are supposed to do the household chores, and it was very difficult to counsel the relatives. They also need rehab, and you have to bring them for rehab for long-term improvement. Can we go to next slide, Saili? But still, despite these challenges, some of our patients, the feedback really helped us to continue with this rehab center. Like Kamla, she said, yes, initially I used to feel weak, I used to feel a bit of breathless after doing any work, but now I'm okay, almost near normal. Same with another patient, Mr. SP, I've changed his name, only those initials are there. But if you see the sessions attended, you'll see they have attended almost all sessions. Not only that, after realizing the rehab is working, they are ready to come for maintenance phase also. So at the end of 9 months, I realized rehab works, but counseling is important. The main thing is whether patients or patients' relatives or whether my colleagues, invariably, when I tell the patient to do something, everybody is a bit unhappy. They want prescription of medicines. If necessary, they are ready to bring oxygen also. But the moment I tell them they have to do some exercise, they have to come and do attend some sessions so that they can optimize their lung function. Somehow relatives or patients themselves sometimes are not ready. But at the same time, once they start coming and they realize it is helping them, then they continue doing it. At the same time, the another problem I realize is sensitization or awareness amongst even medicos. To give you example, initially, uh, even my residents, they used to say, ma'am, the saturation at rest is 95, so I don't think he needs rehab. But social worker, after spending enough time doing 6 minutes, he used to come and tell me, ma'am, after moving around, the patient says, because thanks to COVID, everybody had pulse ox with them, he's desaturating. So I think they need rehab. So that is how we included patients in our rehab, thanks to our social worker. And at the end of 9 months, I can say my team is now really well versed with whom to include, how to counsel, and how to give benefit of this rehab to post-COVID patients. Sally, next slide. Thank you. Thank you, sir.
Thank you, Dr. Medha. It was a nice deliberation. It is something new to us, very new to us. Now the question answer session, because we have crossed 90 minutes. As a chairperson, I am a privileged one. And that's why the first question I will ask to first two speakers, Dr. Jayant first, and Robinda will answer the second one.
Right.
Now we are seeing mainly the post-COVID scenario. Dr. Jayanta Roy, can you tell us what are the common presentation of post-COVID patients And same to Dr. Rabin Chakraborty. And what are the advice from your side to the physicians to refer the patients to you, the post-COVID scenario? Dr. Jayanta.
Okay. Thank you, sir. It's very interesting questions, very practical. I think we are here to understand that how the post-COVID phase is unfolding in our clinical practice, because we do see a lot of neurological disease entities, common disease entities I'm talking about, say stroke, epilepsy, or different polyneuropathy in terms of GB syndrome or something like that. In some myelopathies like transverse myelitis, many of these patients were COVID positive at certain point of time. So the question is whether this is a direct fallout of their COVID infection, or they are like any other pre-COVID conditions. I mean, unless we study them systematically to see whether those incidents are actually increased in post-COVID compared to the pre-COVID era, we cannot really comment. But two things I like to mention here. One is clearly the vaccine-related neurological syndromes, we have seen a few, like transverse myelitis. We have seen a number of transverse myelitis in a very close proximity with vaccinations. And second is some young strokes we have seen, which are again in close proximity with their COVID infections, and these are well known. But looking at the chronicity of the disease process, whether chronic neurological syndromes, as I mentioned in my talk, like Parkinsonism or other movement disorders, we are not very sure. But one thing I must mention here, that we have seen a few patients who presented with a multiplicity of symptoms, not very well defined. Post-COVID phase, we found their COVID antibodies high. Many of them got benefited with IVIG. When we found they are presenting with some kind of immunological disease in form of some movement disorder, some encephalopathy, some confusional state, and without any definite clue what is the disease entity post-COVID, we treated them with IVIG and we got results. So I think this is one area which will unfold to us in the coming days, and we will definitely keep it in mind, the long-term immunological implication of this disease on the nervous system, and we'll definitely follow them up, and maybe we'll come up with more accurate answers.
Thank you, Dr. Rai. Dr. Rabin Chakraborty, please, post-COVID.
Yeah, the very straightforward answer. One is those patients who had pre-existing cardiovascular diseases, like previous angioplasty, bypass surgery, already pre-existing left ventricular dysfunction, and known heart patient, valvular heart, whatever may be the heart disease. If that patient happens to suffer from COVID at some stage, and after recovery from the COVID infection, once the patient comes back home, it is important and it must be a part of protocol to send them to a cardiologist for further evaluation. That is one. Second, those patients who had a COVID infection but without any pre-existing cardiovascular disease, if those patients had an echocardiographic evidence of left ventricular dysfunction, like low ejection fraction, or if there is an evidence of electrocardiographic abnormalities like STT changes or a change of the ECG after the COVID infection, provided they were pre-existing previous ECG, or in case they have got some evidence of pericardial effusion, it may be a good idea to send to a cardiologist. Third, normally these COVID group of patients are being seen by the physicians and at times seen by the pulmonologist. If the concerned physician feels, particularly the pulmonologist, if they feel that this patient, after being adequately treated for lung condition, after being adequately evaluated for lung condition by whatever way they do it, by follow-up of CT scan, lung function test, and therapy treatments, patient is not improving, then it may be a good idea to send to a cardiologist.
Okay. There are some questions in the chat box. I am giving one or two questions to Dr. Rabin Chakraborty, please. One from Dr. Lilavati Thakur, probably from Durgapur. Recently, we are seeing a significant rise in young ACS patients with significant DVD or even TVD. May that be a complication of subclinical COVID-19? Dr. Chakraborty, please.
Right. It's an assumption, but it's very important to know whether they were tested for COVID at some point of time. If they were not tested for COVID, then it is just a prediction or a guess or assumption.
Yes, yes.
But having said that, in case, let us see that that's a previous COVID infection, so how that is going to matter, because treatment remains the same, isn't it? Like,
Okay. Another question from Dr. Anjan Dotto. I don't know whether our cardiologist Anjan or not. To Dr. Rabin Chakraborty, can COVID produce uncontrolled supraventricular tachycardia?
Well, the COVID, firstly, the supraventricular tachycardia is a broad term. We don't know. The usual supraventricular tachycardia that we know, like atrioventricular nodal rate tachycardia or other things, is usually rare. The common thing is atrial fibrillation. That is the commonest kind of supraventricular tachycardia. In some patients, they have atrial tachycardia. Now, atrial tachycardia, as such, COVID reporting as atrial tachycardia is less common, because usually it quickly degenerates into atrial fibrillation. So yes, atrial fibrillation is a very common and known kind of cardiac arrhythmia complications of COVID during acute stage, even after the long term. It could be the manifestation of an underlying substrate like cardiomyopathy or even coexisting ischemic heart disease. So that it's a known thing. If we find that patient is presenting with that, it's important to investigate, particularly to exclude ischemic heart disease, and also to before that echocardiogram to exclude any myocardial dysfunction.
Okay, in a quick succession, next question from Anupama Murthy. We have seen post-COVID or COVID Guillain-Barré syndrome, probably due to post-infectious immune-mediated complication. We have seen all of these patients, GBS. How to treat it? Dr. Jayanta.
Well, I think COVID is not the only infection which has triggered a GBS kind of thing. We have seen many infections in the past, including viral infections, gut infections. They triggered this GB syndrome. So COVID is one of them. So the treatment of GB syndrome post-COVID is same like other GB syndrome. You have to treat them with IVIG or plasmapheresis. But yes, they should be carefully evaluated for their other system involvement, because if the patient goes into ventilator with a bad COVID pneumonia and other thromboembolic manifestations, I think the prognosis of that GB syndrome is worse than what we used to see earlier. So that has to be kept in mind, but the treatment is same.
Okay. Now my question to Dr. Medha. What are the ways to see the impact of pulmonary rehab in post-COVID patients? What are the ways to see the impact of pulmonary rehab in post-COVID patients?
It is a bit difficult, sir, because as of now, like I said, we have finished 9 months. Whoever is completing 2 months, we are repeating 6 minutes and quality of life. Now, as everybody knows, rehab won't change the lung fibrosis or lung changes. But definitely in rehab, we teach the patient how to optimize his compromised lung function by maybe giving him breathing exercises, change breathing technique. At the same time, because they have got breathlessness due to lung function, impaired lung function, there may be other things like immobility and impaired nutrition. So definitely with proper counseling on all fronts, we do see change in quality of life. As far as 6 minutes is concerned, in some of the patient, post-COVID patients, we could see the change. But we really don't know at this point of time whether it is because of rehab or because of natural course of, post-viral improvement. But quality of life, definitely there is impact.
Yeah. Achha, another question, just a minute. Good question too. Dr. Rabin Chakraborty from the same person, Anupama. There are two questions. Post-COVID, we have, How long to continue the anticoagulants in patients of post-COVID with comorbidities? And the second one is MRI better to diagnose myocarditis than other investigations? Ravinda, please.
Good question. Firstly, the protocol for anticoagulant is very standard. If the patient, they do not have any comorbidity, the standard recommendation is after discharge, continue at least for 3 months, NOAC, at least, if not more. And also monitor your the markers, some of those markers has to be monitored, particularly interleukin and other kind of things, or IL-6 and other those kind of things to be monitored. If the patient has got a pre-existing condition, for example, cardiovascular disorder, depending on the situation, if the patient is already in a condition which demands a long-term anticoagulant, for example, atrial fibrillation with CHAD score more than 2, then lifelong anticoagulation. If the condition is without any such problem, then at least 6 months and then evaluate accordingly. That is anticoagulant. Coming back to any other thing, that is the question.
Okay, Dr. Jayanta, I have a simple question to you. I have come across 7 patients of convulsions. And everybody of my friends all over India is telling Dr. Kundu, please see whether there is superior sagittal sinus thrombosis present or not. But none of the patient has got superior sagittal sinus thrombosis, and all the 7 patients I could not make the cause of convulsion in COVID. What is the cause? Is it the retrograde transmission of the infection through cribriform plate? I don't know.
COVID can cause encephalitis or encephalopathy by the direct invasion, though there are other mechanisms like hypoxia or sometimes drug interactions. So hypoxia can make your brain vulnerable to seizure due to other factors. The seizure threshold is lowered. So I think at times it is multifactorial, but it is very common to have encephalitis or encephalopathy followed by COVID, and number of MRI studies have shown that parenchymal changes are visible in post-COVID, especially in the basal ganglia region and also in other areas. So direct viral involvement can cause seizure if we consider other factors like systemic factors or drug interactions separately.
Okay. Dr. Chakraborty, have you treated any one patient who is not previously under AC inhibitor? Have you added AC inhibitor in any of your patients? You have seen so many patients.
Well, if the patient is already not on any ACE inhibitors or ARB, and the blood pressure, the first line of treatment, of course, not ACE inhibitor or ARB for hypertension. In those situations, we actually start with calcium channel blocker. That is a recommendation. If the patient has got a persistent tachycardia, and if there is evidence of mild LV dysfunction, beta blocker is a good drug. So combination of beta blocker and calcium channel blocker. In mild LV dysfunction, if the ejection fraction is more than 45 or even 50%, the new generation of calcium channel blocker is safe. But in certain situations, the pressure is not really getting under control. And if the situation demands, then we can commence with a small dose of ARB probably.
Okay. One of the question again from Dr. Lilavati Thakur, beautiful question to both the clinicians first, Dr. Jayant and this one, Ravinda. I have treated a young lady who presented with both ischemic cerebral stroke together with significant pulmonary thrombosis. How common is this? Anyone can answer. Jayanta?
Well, we know that thromboembolic manifestations are quite common. I mean, systemic, not only lung. But systemic thromboembolic complications are quite common in COVID. And one thing I like to mention here is that patients who got stroke in COVID, ischemic stroke in COVID, their usual stroke risk factors were higher as compared to other patients. So patients who are diabetic, hypertensive, with a vascular disease or other stroke risk factors, known stroke risk factors, their vulnerability is higher. And COVID, due to their inflammatory reactions, can make changes to the stable plaque and can make them unstable plaque, increases the chance of further ischemic stroke. So COVID can modify your background milieu of stroke to cause more stroke in addition to thromboembolic mechanism which happens due to COVID itself.
Okay, coming back to this question again, Arup answered it very straightforward.
Yeah.
One is that
Yeah.
some of the thromboembolic manifestations are clinically evident,
Correct.
like patient either CVA or even cardiovascular or pulmonary. But you have to understand that it has been shown that many of these patients may have a clinical manifestation like a cerebrovascular embolic stroke or pulmonary thromboembolism. But if they die, and once they have done postmortem, they have shown that a lot of organs have microthrombi in other organs.
Correct. That's the answer. Yeah. Correct. My next question is to Dr. Medha. Would it be possible for you to describe the methodology of post-COVID rehab in a quick succession of 1 to 2 minutes?
Like I said, it is 8 weeks program, twice a week.
Yeah.
And we do pre-assessment. Depending on patient's condition, we prescribe the exercises. And after 8 weeks, we repeat 6 minutes and quality of life.
Okay, it's not
That
possible
is
to show
really,
it
I
here.
mean, a compact answer to this
Okay.
question.
I ask the audience if there is any other question. Dr. Partho, you can take over. Beautiful session by everybody. Partho.
Chairman,
Dr.
sir,
Partho,
can I add one point?
Yeah, definitely.
Dr. Leelabati has posted another interesting point that, I mean, as in regard to her his previous question, stroke and pulmonary embolism.
Yes.
I had to hold back heparin due to size of the cerebral stroke. I think this is a catch-22 situation. There are conditions where ischemic stroke, where we do not usually anticoagulate them in the acute phase, especially in large stroke, because of the chance of hemorrhagic transformation.
Correct.
And the study shows there is no benefit of acutely anticoagulating in patient to prevent further stroke. But in cardioembolic stroke, we definitely anticoagulate them for a long term. And the initiation of anticoagulation varies depending on the size of the stroke. But in this particular case, when the patient has got a thromboembolic manifestations elsewhere, patients might need heparin, though there is a stroke. But I think the other thromboembolism, like pulmonary embolism or pulmonary thrombus, takes a precedence, and we may have to continue heparin in presence of an ischemic stroke, maybe a large stroke, but to consider the patient's condition, we can probably give it.
Nice. Dr. Chakraborty, Rabin Chakraborty, two of my patients came to me after COVID. They are long haulers. After 3 months, they have got pulse rate of 130. No problem, no complaint, no irregularity. Going to their office. Is it an autonomic phenomenon going on?
It is a sinus tachycardia. Some of these patients, what happens that it's a kind of inappropriate behavior of the sinus node. But I have to say that even if they do not have any symptom now, such kind of, this is called incessant sinus tachycardia, when the rate is persistently more than 120 or so. On a long-term basis, they may actually develop tachycardia-induced cardiomyopathy.
Harish, okay, nice program. Dr. Partho Bhattacharya, if you have got any question to the speakers or any of the audience, sufficient questions have been delivered to the speakers, all the speakers. It's a nice program. Dr. Partho?
Yeah, I don't have any questions to ask, but I have got thanks to offer to all my faculty members. I find one question, how long to continue the anti-fibrotics for lungs? So that also is a very important issue. I just want to touch that question. Since there is no good study to tell clearly how long one should give anti-fibrotics, we have been observing the effect of anti-fibrotic in lung involvement with COVID, and we find that there is improvement. And of late, we have had some statistical analysis of our data, which shows that anti-fibrotics perhaps enhance the improvement of lung fibrosis, and that is yet to be published. But we never know how long it to be continued. In fact, it has been found in SARS-1 that 5% of the patients have got long-term sequelae even after 15 years. So taking the bulk of COVID-19, it is possible that we'll have a far, far bigger bulk of patients if that 5% figure remains. And with that, we must be proactive to treat, and with these patients, possibly with anti-fibrotic.
Correct.
So there's no clear answer yet, but yes, anti-fibrotic is likely to have a role, and a lot of people are using, a lot of studies are undergoing. hopefully in future we'll have a clear answer about it. So that's all about anti-fibrotic.
Nice. So Partho, it should be
So thank you very much,
concluded.
Arup, for kindly chairing
Thank-
this wonderful
thank-
session.
I
It
am
has been very, very exciting. I am very thankful to Jayanta Roy, who has taken the pain, and Dr. Rabin Chakraborty as well, and Dr. Medha. It's been a wonderful discourse and very good
Wonderful
interactions with them. Yeah. So I'm looking forward the next sessions to be equally important. We have got another session to be followed soon with microbiology, new developments in microbiology for the lung diseases, and omics for clinicians, followed by another very important session by one of the major international faculty, Charles Shammers from UK, who is an international authority of non-tubercular mycobacterial infections and bronchiectasis. He is presently the deputy chair of the European Respiratory Journal. So we are looking for next 2 sessions, very important. We have got another 3-4 sessions left with. So I request all my audience to propagate the message. We are trying our best to make the sessions interesting and informative. We hope to see you again. And with thanks to once again to my esteemed faculty members and to my audience, I wish to say goodbye and good night.
Goodbye. Thank you.
Thank you.